Hey guys, today we're going to talk about disc herniation or disc displacement. If you notice, I have disc D-I-S-K. Disc can also be spelled D-I-S-C. There's two versions of that. Your book uses the D-I-S-K, so that's what we're going with here in the PowerPoint. The disc itself is composed of two parts, and it's the annulus fibers, which is an outer connecting ring, and then an internal nucleus pulpus, which is more of a jelly-like substance. These two components together make the intravertebral disc itself. It usually sits between the vertebrae of the spine, and its purpose is to provide cushion during movement. We're going to talk about the displacement of this disc in this PowerPoint presentation. Usually displacement is due to a strenuous activity or an injury to the spine itself. There's several words that you may hear that can be used interchangeably, that can be synonymous to each other. Some of these are the prolapse, herniation, rupture, or extrusion of the disc. But two that I want to talk about specifically that are probably most common is the bulging disc. And basically the bulging disc and its difference between the herniated disc. The bulging disc is where there's no tear or rupture of that outer annulus layer, and so the disc itself just kind of has moved out of its normal area of sitting between the two vertebrae. A herniated disc is where there is actually a tear or a rupture in that annulus layer, and a portion of the jelly or the nucleus pulpus has leaked into the spinal canal. The herniated disc might have started off actually as a bulging disc and then proceeded to herniate where there was a tear in that outer wall of the disc. Disc displacement can actually occur at any level in the spinal column. It's most common in the lumbar spine, specifically L4, L5 is the most common level of injury. With the displacement, the disc can press on the spinal cord itself or on one of the spinal nerves, which is just lateral to the spinal cord. When there's injury to the spinal cord or to the spinal nerves beside the spinal cord, that's when you actually start having the symptoms associated with the disc displacement. Pain can be exacerbated by straining, strenuous activities, prolonged sitting, and our goal is to relieve this pain, and we can relieve the pain by laying on the side with the knees bent or in a recliner type position, also known as a Williams position, is that semi-sitting reclined position. And then if you're laying supine with pillows under the legs, can also alleviate some of the pain in the lower back. This position, basically the Williams position, relaxes the muscles of the lower back and relieves pressure on the spinal nerve roots. Of course, our goal is to reduce pain and spasms and improve mobility, and if we need to, repairing any structural problems with the spine or the disc itself. Some of the things that we can do that are non-surgical management of disc herniation or disc pain is positioning. Again, like I said, the Williams position, whereas the semi-Fowler's position, pillows under the knee to keep them flexed, or kind of like sitting in a recliner. Also exercising, isometric exercises, which is basically exercising without muscle movement. And there's two examples here. The plank is an example of an isometric exercise. Basically there's muscle contraction, but there's no lengthening or shortening of the muscle during that contraction. And then we can also use drug therapy, NSAIDs, muscle relaxers, Anti-epileptic medications can also be used along with steroids and epidural injections. You notice that opioid analgesics are not on that list, and the reason is they have been shown to be no more effective than the non-steroidal analgesics in providing pain relief. However, on occasion they're used on a short-term basis, but they won't. You don't want to use them long-term. And then steroids may also be used, usually in a tapering dose, to rapidly reduce inflammation of the back. Along with drug therapy, patients may also use heat or ice therapy. Most often it's a moist heat. And what heat does is it increases the blood flow to the affected area and promotes healing of the injured nerves. Usually it's 20 to 30 minutes, at least 4 times a day is what's recommended for heat therapy. We also want to worry about diet and weight control. Weight control often helps reduce chronic low back pain by decreasing the work on the vertebrae caused by the excess weight. However, remember, weight can be a sensitive topic, so just be aware of the way you approach a patient in weight. And then there's also the percutaneous laser disc decompression, which is used with like fluoroscope and the insertion of an endoscopic. It's next to the affected disc. This is a minimally invasive procedure where they use laser to remove that portion of the disc that's touching the nerve. Again, surgical management is usually performed if conservative non-surgical measures have failed to alleviate the back pain or the neurological defects that are associated with the disc. Some alternatives to non-surgical management, which are non-surgical managements, can be like spinal manipulation with a chiropractor or ergonomics. And here are just some example picture-wise. The one to your left, of course, they're not using ergonomics in their favor. And ergonomics is basically an applied science which the workplace is designed to increase work comfort, thereby reducing injury while increasing efficiency and productivity. And then to your right, the middle picture and the right picture are both using ergonomics, either at the desk where it's the workstation is an ergonomic workstation, or in the correct way of picking a box up, both to decrease injury or the likelihood of injury. And you'll find that once you actually get into the workforce, especially in nursing, in your orientation, they'll spend a lot of time on this because back injuries is one of the #1 injuries to nurses. So they'll spend a lot of time on ways that you can reduce back injury as a nurse. So if our non-surgical treatment has not worked, we can use surgical management. And this is basically when the sciatica or the pain is severe and disabling, or there is a nerve root dysfunction. Some of these surgeries include the discectomy, the laminectomy, spinal fusions, the percutaneous discectomy, and we'll talk about all these here coming up in these next couple of slides. Your discectomy is just that. It is the removal of that part of the disc that is invading the nerve space or on the spinal nerve or the spinal cord itself. It's a very common surgical procedure, and it removes the herniated disc to relieve pressure on the nerve root. The laminectomy is also used usually in conjunction with the discectomy. It's the removal of the lamin or lami, which is part of the bone, in order to get to the disc. This is the approach through the back, where they'll actually remove part of that lamin or that bone to get to the disc space. And then if you've had repeated laminectomies, or there's instability in the spine, sometimes they'll perform the spinal fusion, and that's basically where they use chips of bone, and they typically remove this from the iliac crest, or they use donor bone along with instrumentation, metal implants, usually titanium, pins or screws, and sometimes plates or rods. They use the donor bone along with the instrument to make the spinal column more steady, and this is usually when there's an unsteady or unstable spine. The percutaneous discectomy is, again, we spoke about it earlier. It's basically where they go in and remove with a trocar just the disc that's impeding on the spinal nerve or spinal root, and then they can use the laser to destroy the damaged disc. You have the microdiscectomy, and we'll watch just a short little video on the microdiscectomy. But this is a very common procedure. The pros to this procedure is that it's done with just a small incision, so there's less trauma and less dissecting of muscles and ligaments and tendons around the spine with the microdiscectomy. And let me show you this video.
Lumbar disc microsurgery. This minimally invasive technique is used to remove the herniated portion of a vertebral disc. It is 95 to 98% effective in eliminating leg pain, called sciatica, which is caused by nerve root compression. The procedure is performed through a small incision on the back. After creating a small incision directly over the herniated disc, the surgeon creates a small window in the lamina, that's the bone covering the spinal canal. The pinched nerve root and the herniated disc can be seen through this opening. The surgeon uses a nerve retractor to gently move the spinal nerve away from the herniated disc. The herniated portion of the disc is removed, eliminating pressure on the nerve root. Only the damaged portion of the disc is removed, leaving any healthy disc material to perform its function as a cushion between the vertebrae. The tools are removed and the spinal nerve returns to its normal position. The incision is closed.
Alright, and then there's also the laser-assisted laparoscopic lumbar discectomy, and again, that's where they use the laser along with the microdiscectomy to remove the part of the disc that's impeding on the nerve. This approach is actually usually done through an umbilical incision, so they actually go through the front of the body instead of in the back side of the body. Alright, so preoperative care. What can we do to help alleviate some of the pain in the preoperative patient? Well, positioning. If they have braces, make sure that the brace fits. Make sure that the donor site is prepped or has been cleaned or shaved or whatever, depending on where they're going to remove bone from. and then make sure that there's an informed consent sign, and that we actually start working on discharge teaching prior to the surgery. And one of those is the smoking cessation. And the big thing with that is because we want them to try to quit smoking prior to surgery. So when they come in for their surgical procedure, that their healing will be better because of the decrease in smoking, or if they've quit smoking. And then post-operative care, initially after surgery they'll go to the PACU, and of course it's vital sign monitoring, the neurological assessments, pain. If they have a dressing, we're monitoring what the dressing may look like. We're going to check to see if there's a dura tear and see if they've got like the CSF leak, if they develop the spinal headaches or start complaining of the severe headaches. If they have drains, we're going to make sure that those JP drains stay charged, or we empty them and chart what's being removed out of the drain. Positioning, depending on what procedure they had done and where in the spinal column it was done, in order to move the patient, you may have to log roll the patient. And of course we want to keep them from developing DVTs, so the SCDs or TEDs, and then bed rest depending on how long or what surgery that they had done. Some complications that can be seen from surgery, well, they can develop a nosocomial infection, which we hope to prevent. But there can also be nerve damage while they're removing that disc that's impeding on the nerve. They can have the dura tear, like I said, which is cause the CSF leak, and they can develop the spinal headaches. They can develop a hematoma, and this is real common, especially on the cervical, the anterior cervical discectomies. So you want to watch for the trachea, making sure trachea is midline, they're not having any tracheal deviation, and that you don't see a hematoma forming. Again, you want to have some smoking cessation. You want to encourage them to quit smoking to promote healing. And then if they've had a spinal, or they've had a lumbar area nerve worked on, you have to worry about urinary retention, especially in men. You want to make sure that they're able to urinate before they leave if they're same-day surgery. Because they're put to sleep, there's always the risk for the paralytic ileus. And then there's a chart on page 987. It's chart 45-4 with complications and what you might see in assessment and intervention. You might want to review that chart also. And then prognosis. Usually prognosis is pretty good. Once they remove the portion of the disc impeding on the nerve, it may take weeks or months for them to regain all of the sensation, maybe down the leg or function of the leg after rehab. But in occasion, they have what they call the failed back surgery syndrome, and this is usually a combination of things. This is usually a combination of several back surgeries that might have failed, along with some depression with the patient, having to have long-term pain management control, but that is identified as a failed back surgery syndrome, but it's usually a combination. These patients will need long-term pain management and a support system because of the depression that can occur with it.